Welcome to everyone to our webinar on COVID-19 reflections and the path to recovery.
Next speaker will be Nathan Thielman. Nathan is an infectious disease specialist and professor of medicine and global health at Duke University. He's founding director for Global Health Pathway, also at Duke. He directs the Masters of Science in a Global Health Program and co-director the NIH sponsored research on AIDS. He's an author of 150 articles and book chapters, primarily focused on HIV. He helped to lead Duke University's Ebola response effort in West Africa during the 2014 and 2016 outbreak. His work on lessons learned from conducting Ebola clinical research in Liberia and Sierra Leone was published in the journal Clinical Trials, which is very much applicable to our current status of COVID-19. Just to add to that, Nathan was actually scheduled to be a visiting professor to Jordan University back on March. However, COVID hit everything and everything canceled and suspended around the world. Nathan, thank you.
Thank you, Wael, and thanks to the organizers and yourself for inviting me today. I'm honored to participate in this important event and to share with you some of the information describing key interventions that can help slow the spread of SARS-CoV-2. It's important to note from the outset, and this will be a recurring theme as we discuss these things, that these interventions slow, but they do not stop the spread of SARS-CoV-2 in its tracks. And when they're used, the number of infections decline. When they're stopped, the number of infections increases. And until we have a vaccine that is safe and effective and that is widely acceptable, it's hard to see us not using some combination of these interventions for the foreseeable future. As Wael mentioned, actually about 7 months ago, this was the flyer that was that he had circulated, and I was planning to give a talk on learning from and adapting to global health emergencies, Ebola and COVID-19. And wow, what a 7 months it has been. In my wildest dreams, I would not have imagined that we would be doing this today as we are. And I will say, you know, I'd planned on being there on March 17th. And it was just around that time that the epidemic was really starting to take off. My travel was to take me actually through Italy, and also I was going to spend time with research partners in Tanzania and Kenya. And as I started looking at the numbers, I got a little nervous and said, you know, I think it's probably not the best time to travel. And so we wound up canceling this talk. It was really sad to have to do so, but I think it was the right call. And this is the only slide that I'm going to show from that original presentation that I was working on that had to be canceled. And I think it's actually prescient and applicable. And the main lesson learned from my experience and the experience of others in trying to work with the Ebola outbreak in West Africa, at least for me, as I tried to stand up clinical research effort there, was that a research response needs to be robust and it needs to be rapidly integrated with the public health emergency response so that interventions to prevent the spread and to treat the disease can be brought on board rapidly. And so in the Ebola epidemic, as you can see in the slide, most of the clinical trials work was just getting ramped up at the time that the epidemic began to wane. And that's certainly not the case, sadly, now with COVID. The epidemic continues, and I've just shown on the slide that these were the places, the number of confirmed cases of COVID per 1 million people back on March 17, 2020, and here's where we are today in the countries that I was planning on traveling back then. And so it's really become a worldwide issue. Just this week, the U.S. Centers for Disease Control reported 8.83 million total cases and over 227,000 total deaths in the United States alone, 500,000 cases in the past 7 days. And I'm sorry to see the uptick in cases in Jordan as well. Well, despite that rather grim graph, because of good research that's been done and that is being done, I do think we can begin to estimate some of the effect sizes of some of the key non-pharmaceutical interventions. And in particular, what I want to do in the next few minutes is drill down on some of the data for you regarding masking and distancing and various lockdowns and their impact. I also want to touch on what it means to care for socially vulnerable populations and the disproportionate impact, at least in the United States, that we've seen of COVID-19 on our socially vulnerable populations. I want to also, of course, briefly mention vaccines, and then we'll just close with a word or two about leadership. All of which I think are key interventions for us to consider as we think about slowing the spread of SARS-CoV-2. Before we begin to discuss these interventions, I think it's important to state up front what is fundamentally known about SARS-CoV-2 transmission, mainly that it's acquired through respiratory droplets when close, within 6 feet, we think, to an infected person, but also sometimes through droplets and particles that remain aerosolized over time and may extend beyond 6 feet. Direct contact is also important. I was reminded of this this week because a patient I saw in clinic on Wednesday, just after I saw him, wound up testing positive. So I had contacted the patient, even though I was wearing the mask and trying to follow all the appropriate protocols, but when I was talking to employee health, they were like, direct contact, even with mask and everything else, you need to go in isolation, which is why I slept upstairs last night, but I'm thankfully negative. And also there's less commonly, we think early on in the epidemic here, we were kind of washing our groceries when we brought them in from the grocery store, et cetera. Less commonly now, we think, is it transmitted through contact with contaminated surfaces, but that's hard to quantify. And so it is important to still be appropriately considerate of contact through contaminated surfaces. And critically important to all of this, and I think one of the reasons why SARS-CoV-2, COVID-19 has become such an issue is the issue with asymptomatic and pre-symptomatic spread up to 48 hours prior to symptoms. Also, it just bears mention that virus is found in stool, blood, semen, and ocular secretions, but the role in transmission for those body fluids is not quite as clear. Well, these fundamentals, I think, are illustrated well by 2 outbreaks that I would like to share with you that the CDC, the Centers for Disease Control in the U.S., reported just over the last 2 months. And in a sense, I think these are natural experiments, if you will, that demonstrate some of the important transmission characteristics of this virus. The first describes an outbreak in June. This was at an overnight camp in the state of Georgia. Of course, at this time, the pandemic was well underway in the United States, and the camp sought to limit the spread of the virus by requiring the following. They required that camp attendees have a negative test. They actually cohorted the attendees. They required distancing measures while they were outside. There was partial masking, but not for all participants. And as you'll see here, this strategy failed abysmally across all age groups, all types of attendees, all cabin sizes. The virus spread to 44% of these 597 individuals. Natural experiment number 2. This was actually just reported this week in the MMWR. Similar story. This time from the state of Wisconsin at an overnight youth retreat that brought in boys from across the US from 21 different states and from 2 other countries, the organizers required documentation of either positive serology within 3 months, a negative SARS-CoV-2 PCR within 7 days before travel, self-quarantine within their households for 7 days prior to travel, and wearing masks during travel. But during the retreat itself, there was no mask or distancing requirement. And what ultimately happened is that one student who, like all the others, had tested negative prior to camp arrival, that student developed a sore throat, a cough, chills, had a positive PCR test on July 5th. And this student subsequently learned that a family member had received a positive PCR test about a week after his departure. Well, at that retreat, that individual was isolated in a private room. 11 of his close contacts, including 4 roommates, were quarantined. They got a rapid test by report that was an antigen test, and those tests were negatives. They were released from quarantine, and then 6 of the 11 actually started becoming ill, and then others started becoming ill. And so here we have another outbreak during this retreat, as is shown here with the epidemic curve. And so quite a number of individuals became ill. At the end of this, 76% were diagnosed with COVID during the retreat. So what are the lessons learned here? Well, I think one is that a multi-component COVID-19 mitigation plan is critical. And there was a good faith effort, I think, on the part of the organizers to try to move in this direction, but there was a pretty serious omission. They omitted, I think, what are the best interventions. You'll see this illustration periodically through the remainder of my slides here. And I really like it. I think it makes the point that no single intervention right now is 100%. And it's kind of like trying to line up different slices of Swiss cheese. And if you line them up such that the holes do not align, you will have effective intervention when you have multiple components. And so it's important to think about this. We've actually been doing this for years in HIV medicine, and we've talked about the importance of combination prevention efforts to stop the spread. And I think those have been quite successful. And I think that's a lesson that we need to bring to COVID. So what are some of the data? I'd like to just drill down with you for some of the evidence for prevention. And specifically, we'll just talk about what I think is really the best compilation of data that came out this summer from Derek Chu and colleagues from the COVID-19 Systematic Urgent Review Group effort. And it was published in this systematic review and meta-analysis in Lancet. And they reviewed any studies that had designs evaluating physical distancing, face masking, and eye protection to prevent transmission of viruses that cause COVID-19, and also related diseases like SARS and MERS between infected individuals and their close contacts, i.e. household members, caregivers, and healthcare workers. So shown here in the first row here is the transmission of viruses with physical distancing of 1 meter or more compared with a distance of 1 meter or less. And essentially this was actually quite significant that the further away you were from an individual who was infected, the less likely you were to become infected. And it's illustrated, I think, it's a little bit easier to digest with fewer numbers when you look at this infographic that also the Lancet published around this time, that with less distancing for these particular infections, and these are epidemiologic studies, there are lots of caveats that have to be included, but the analysis was pretty rigorous, and the level of certainty for this estimate, by the way, was considered to be moderate using the grade criteria. If the distancing was less than 1 meter, transmission was around 12.8%. If it was 1 meter or more, distancing transmission was 2.6%. And for every meter further away in distancing, the relative effect was thought to increase. So I think that it's pretty solid here. Distancing works. What about masking? Well, across 10 adjusted studies, the face mask use was estimated to result in a large reduction in risk of infection as well. Here, the numbers were a little bit smaller overall, with around 2,647 participants. But looking at the use of a face mask versus non-face mask, and I will say this was a combination of N95 respirators and disposable surgical masks. And again, you can see that the difference between the two was 14.3%. And just viewed in a different way here, the chance of infection or transmission without the use of masks or respirators was 17.4%. With mask or respirators was 3.1%. The level of evidence here and the certainty of evidence here was estimated to be low. But I'll also point out to you that I think there's some pretty good data from our colleagues in environmental sciences and physicists indicating that these interventions actually do make a big difference. And finally, I'll also just point out to you that eye protection was also associated with less infection, here from 16% to 5.5%. So those are, I think, the best data. If anyone needs convincing on this, if you need to talk to policymakers about it, I think that the level of evidence here is quite strong. But again, I'll also point out one more time, none of these interventions is completely effective. And it's their use in combination that is so critically important as we think about how we slow the risk. I like this infographic. This is from Chip Schooley and colleagues, who actually, in their compilation, they talked about combining masking and testing to combat asymptomatic spread of SARS-CoV-2 in this science commentary. I like the illustration. It highlights how if I'm wearing a mask and I'm healthy, that helps some, but if the person who has COVID and is asymptomatic is wearing a mask and I'm wearing a mask, then we really are starting to get at an additional way to reduce transmission. Well, 1918, it is a little bit humbling when we think about 1918 that we're actually kind of doing the same thing, aren't we? It's humbling to recognize that we've been reduced to similar prevention measures that were used more than a century ago. In another sense, I think it's helpful to recognize that there are others who've gone before us who've faced similar, if not more deadly threats, and have gotten through it using a combination of mitigation strategies. And it's kind of interesting. I won't read this whole thing for you, but you know, wearing a mask, I'm not going to argue with living a clean and healthy life, washing your hands, reporting early symptoms, respecting quarantine regulations, avoiding crowds, listening to the specialists. There's a lot to embrace in these recommendations from over a century ago. And in fact, with far less evidence than we discuss now, mass use was encouraged in the 1918 epidemic. Well, it's one thing to look at evidence for these non-pharmaceutical measures from systematic reviews, meta-analyses, and even history. It's another to try to assess their efficacy as a matter of policy. And on a policy level, does it make a difference when we implement laws and when we implement shutdowns, et cetera? And 7 months into the epidemic, we're starting to see some data to help us understand the impact of these interventions on COVID case numbers. And I'd like to highlight this with you in 1 or 2 studies. One that just came out this week in Lancet Infectious Diseases, and in another is actually a preprint from a colleague of mine. It's on the preprint server here at Duke. This first article looks at the potential associations between country-level reproduction numbers and non-pharmaceutical interventions introduced and lifted throughout the course of the pandemic. Just to back up for you for a moment for context, just remember that R is the reproduction number. It is an epidemiological metric that calculates the average number of people infected by one infected individual. And R value of 1 or higher indicates sustained transmission leading to a growing outbreak, while an R value of less than 1 indicates a shrinking outbreak. And by the way, if you want to read more about these concepts, I highly recommend Adam Kucharski's book, The Rules of Contagion. I started reading it just as COVID was hitting, and it was very helpful for me in just trying to understand and refamiliarize myself with some of these concepts. Well, back to the study. The authors looked at the association of introducing and then lifting non-pharmaceutical interventions with the effective reproductive number, the R number of SARS-CoV-2 across 131 countries. So lots of data here. And just to give you an idea for how this is done, I've lifted one graph off of here. The authors modeled the change in R values as an R ratio from day 1 to day 28, following either the introduction or the relaxation of 8 individual non-pharmaceutical interventions among these 131 countries. So there are too many graphs to show you, but this is what the analysis looks like. Shown in blue here is how the R ratio over time after introducing, for instance, public events ban, you can see the R goes down. So that's a good thing. It's less virus being transmitted. You lift this, and not too surprisingly, after you've lifted the ban, the R goes up. And when they looked at this further, it looked like reopening schools, lifting bans on public events, lifting bans on public gatherings of more than 10 people, lifting requirements to stay at home, and lifting internal movements were associated with an increase of R between 11 and 25% on day 28 following that relaxation. However, the effects of introducing and lifting NPIs were not immediate, so it took a median of about 8 days following the introduction of an NPI to see about a 60% of their maximal reduction of the R ratio, and even longer to observe the maximum increase in R. I think we have some data here that may be helpful for us. All of this, of course, is trade-offs, and I think we heard earlier in the opening remarks from Thomas Friedman how important it is to think about the trade-offs that we're making economically with this. And I don't pretend to be an expert in trying to make those decisions, but it's important to count the cost to try to understand how effective a given intervention is. And so I believe these data are in fact helpful. It was on the basis of the results from the main analysis that the authors estimated the effects of 4 candidates of composite non-pharmaceutical interventions, and the greatest reduction we're seeing for candidate number 4 shown here. Again, the most draconian, school and workplace closure plus bans on public events and gatherings of more than 10 people, plus internal movement limits, plus stay-at-home requirement. This really reduced it quite a bit, and it is a way to get the epidemic under control locally. But again, there are costs associated with this. I want to briefly mention something from a colleague that actually just showed these data to me yesterday, and again, it's on the preprint summer server, that described the heterogeneity of NPIs in their effectiveness in the US before phased reopenings. And I won't get into the methodology behind this. I don't think we have the time to do so. But basically, Bill and his colleagues looked at 4 different levels of interventions compared to level 0. And he basically said this federal policy to block entry to the US for non-US citizens actually had no effect. So that was kind of their baseline. So starting with low effects to higher effects shown here that included things like sheltering in place, wearing a mask, and aggressive travel restrictions. And when they modeled this out, looking at a different metric, not looking at the R, but looking at risk ratios and then effects on the doubling time on the graph on the far right, what you can see is, again, not terribly surprisingly, but it was the more restrictive interventions led to decreased transmission and slowing the doubling time. And these included, again, non-essential business closures, suspending elective medical procedures in hospitals, restricting mass gatherings of more than 10 people, sheltering in place, et cetera. And importantly, Bill actually looked at this across different populations in the United States. So the initial data points were all by county in the US, and then he clustered the counties into the census regions in the US. And one of the sad but interesting and important things that he pointed out was that variables on race and ethnicity and poverty seem to explain variation of COVID-19 cases in the southern United States, which is where I live in North Carolina, but not in other US regions. And it's very consistent with data that we've seen that greater racial and economic disparities are associated with reduced healthcare access for certain US subpopulations. So let me just use that to segue briefly into and I'm just going to show one slide on this. Again, this is just off the press from last week from the MMWR, but it's data that shows an association between social vulnerability and a county's risk for becoming what's known as a COVID-19 hotspot in the US. And I think we all know that communities with higher social vulnerabilities, including poverty and crowded housing units, tend to have more adverse outcomes for a lot of reasons, and that's particularly true following a public health event. So in this analysis, US counties that had greater social vulnerability index, and this is a composite measure of just what you would suspect, social vulnerability. It has to do with income, marginalized populations, and the like. These populations were more likely to become areas with rapidly increasing COVID-19 incidence known as hotspots, especially counties where there were higher percentages of racial and ethnic minority residents and people who were living in crowded housing conditions. This was also seen in less urban areas as well. So the key implication here is that focused public health action is urgently needed to prevent communities that are socially vulnerable from becoming COVID-19 hotspots and to address persistently high COVID-19 incidence in hotspot areas with socially vulnerable populations. And I'm glad to say that I think in our own community here, we've actually seen a strong response to similar data to roll out more testing interventions and to diminish barriers to care, especially for the Hispanic community here locally. So ultimately, the way out of this epidemic is going to be achieving herd immunity. And based on the R0 of estimate of about 2.5 for SARS-CoV-2, it's thought that in order to achieve herd immunity, about 60% of the population must be immune. And in order to achieve that, we're going to have a vaccine. Just last week, Dr. Fauci presented essentially this slide. I've modified it only slightly, showing Operation Warp Speed in the United States. And this is a major investment between the US government and pharmaceutical companies to rapidly scale up and scale out vaccines. It's really been an unprecedented coordination between pharmaceutical companies, the NIH, and regulatory agencies to get to this point. And importantly, there are harmonized protocols with common data and safety monitoring boards. There are common primary and secondary endpoints. They're using common immunological parameters for correlates of immunity. So I think we're really going to advance science and our understanding in a way that we can make important comparisons between these vaccines, and the ones that look most promising can get scaled up to the greatest extent. And there are three different platforms that are being evaluated. One is the nucleic acid platform that's mostly messenger RNA. This is kind of unprecedented. We don't have an mRNA vaccine that's been approved yet. So if this works, this will be groundbreaking. There are viral vector platforms, chimp adenovirus, human adenovirus, VSV vectors, all that are being evaluated, and then protein subunit as well. 2 phase 3 trials in the US were started in late July, and we're very hopeful that we'll have an answer by mid-November or the beginning of December. And so there's some cautious optimism that we may have a safe and effective vaccine in the coming months. But there's a lot that remains to be seen here. We talk about 60% for herd immunity, but that means, the vaccine's likely not going to be 100%. So we're going to have uptake that's likely far in excess of 60%. And so we've got an uphill battle to wage here to get to that point. So finally, let me just close with this slide and say a few words about leadership. We don't talk about leadership in the infectious diseases community much, but I think it's really important for all of us to think about what it means in our various roles. And this is from political leaders to public health officials, to leaders in community settings, to leaders in the workplace. As we seek to apply the best evidence to slow the spread of disease, how can we lead others? Prudence Bushnell was a former US ambassador to Kenya in 1999 when the US embassy there was bombed, and that killed over 200 persons there, wounded over 4,000. She thought a lot about leadership in the middle of a crisis, and I think some of these points really resonate with me now. So thinking about this as a process is important. Recreating normalcy, even if it's an illusion. And I think, when I think about normalcy now, it's the new normal of wearing a mask, right? Oh, so important is avoiding the we, they thinking, the finger pointing and the blaming. Thinking about achievable goals, tolerating diminished results, modeling tone and behaviors. May I repeat? Modeling tone and behaviors, so important for us in the US to think about. I think a really good principle for anyone in leadership is to pay attention to the behaviors of others around us, to reach out to our subordinates, peers, and leaders in need, and to listen well. So these are some interventions for us to think about as we want to slow the spread of SARS-CoV-2, and I want to thank you for your time.
Thank you so much, Nathan, for this outstanding presentation. Probably we'll take a quick question, then we'll move on to the final speaker. So,
yeah, I'll bring forward a question that's related to the Lancet study that you presented, which are, what are the parameters to ban or lifting ban? And you can reference, one of them maybe in the study. And is there any efficacy of one-day lockdown or certain lengths of lockdown related to that?
Just to add to this, Nathan, because I think Jordanian model, they have one intermittent lockdown, which has been also has been used in Turkey and has been used, I think, in Germany at a certain extent. So people, they're wondering about this intermittent lockdown, partial lockdown. So that's just to explain the question.
Yeah, that's a very good question. And I guess I would first say the questioner should probably examine the paper in detail and really look it up. But from the hip, I would say that it looked like whatever intervention was implemented, such as these lockdowns, there was a delay, and it fits what our understanding of the biology of this infection, right? So we're not going to see a decrease for a while, and I think the median was around 8 days or so before you started to see an effect. So how long of a lockdown, I think, is a question I don't know that I have a great answer to. Intuitively, I kind of want to say a couple of weeks seems to me like an appropriate time, but I would defer to others more expert than myself there.
Thank you so much.